shift our session from the clinical order to the platelets. Our next topic is about the ITP beyond the steroids. मैं मैडम से रिक्वेस्ट करूंगा डॉक्टर सलमा ज़ेब, शी इज़ द एसोसिएट प्रोफेसर ऑफ मेडिसिन एट लेडी रीडिंग हॉस्पिटल एंड आल्सो चैप्टर हेड पाकिस्तान सोसाइटी ऑफ इंटरनल मेडिसिन एट पेशावर। अब बियॉन्ड स्टीरॉइड्स हमारे पंजाब में ना जाएं, यहाँ से स्टीरॉइड से ऊपर कुछ भी ओपीडी में नहीं मिलता।
ITP, immune thrombocytopenic purpura. Basically, it's an autoimmune disorder which is characterized by premature destruction of platelets. And this destruction is mediated by autoantibodies which get bind to platelet antigen, leading to their removal by reticuloendothelial system of the body, primarily in the spleen and occasionally in the liver. So, how these patients present? Their presentation is variable. Majority of the patients are completely asymptomatic and their diagnosis is usually incidental. Some patients present with mild mucocutaneous bleed like spontaneous bruising, epistaxis, bleeding gum, and menorrhagia. And 5% of the patients present with life-threatening bleed at the time of diagnosis, which requires hospitalization and emergency therapy. So, as it's a bleeding, as these patients are at risk of bleeding, so how do we assess these patients for the risk of bleeding? The most important is the platelet count, which is directly related to the risk of bleed. The other condition which can also be assessed by taking a good history and examination for assessing this patient for the risk of bleed. One is the history of hemorrhage. If a patient have a previous history of hemorrhage, they are at the risk of bleed. Then the comorbidities, certain comorbidities like CKD, ischemic heart disease, who are already taking antiplatelets, and malignancy patient are at risk of bleed. And certain medications like acetazolamide, digoxin, and aspirin, they actually triggers the antibody production, which then bind to the platelets and accelerate the process of ITP. As I mentioned, only 5% of the patient present with life-threatening bleed at the time of diagnosis, but overall 15% of the patient with immune thrombocytopenic purpura face a lifetime risk of bleed which requires hospitalization within 5 years of their diagnosis. So how do we classify this ITP? Its classification is basically on the basis of duration and etiology. On the basis of duration, ITP can be acute, it can be chronic. Acute ITP usually resolve within 6 months, and it usually occur in kids of both gender, and they usually recover within 6 months of their diagnosis, and they usually doesn't require any long-term treatment, and it usually occur after viral infection. While chronic ITP usually occur in adults of 20 to 50 years of age, and it is not related to any viral infection, and this patient requires monitoring and long-term or second-line therapy. Then on the basis of etiology, it can be primary, which is acute, immune thrombocytopenic purpura, and secondary. Secondary, we always exclude before making our diagnosis of ITP. So the key step in determining the presence of ITP is to rule out other causes of thrombocytopenia. So we need to exclude all these conditions before making a diagnosis of ITP, like certain chronic infections like hepatitis B, hepatitis C, HIV, H. pylori infections are related to ITP, all are related to thrombocytopenia. So we need to exclude this condition by doing the relevant investigation. Then systemic autoimmune disorder like SLE and antiphospholipid antibody syndrome, by taking a good history examination and then doing the ANA and ENA profile. Then chronic liver diseases can be due to these chronic infection, hepatitis B and C, but it can be due to alcohol liver disease, hemochromatosis and Wilson, which leads to pancytopenia or thrombocytopenia, so we need to exclude that as well. And splenomegaly, it can be due to malignancy, it can be due to splenic vein thrombosis, and it can be due to tropical splenomegaly, which is very, very common in our setup where malaria is endemic. So again, a good history examination and investigation. Malignancy, then primary bone marrow disorder. We need to perform bone marrow examination before labeling any patient as autoimmune thrombocytopenic purpura to rule out primary bone marrow disorder like myelodysplastic syndrome and aplastic anemia, which can present initially with thrombocytopenia. Then some heritable thrombocytopenias like Bernard-Solier syndrome and von Willebrand disease, and acute viral infection like cytomegalovirus and infectious mononucleosis. So this slide is a busy slide, and I think I already explained all the differential diagnosis and the recommended investigations. So it is vital to remember that previously corticosteroid, intravenous immune globulins, splenectomy, and anti-RHT immunoglobulins have all been used in the past to treat ITP. But it is crucial to recognize the limitation of these therapies because they haven't been thoroughly investigated in randomized controlled trials. Their efficacy is variable. They have got a well-described side effects and minimal benefit to many patients, and although they are still using as a first line of treatment for newly diagnosed ITP patient, but they frequently lose effectiveness with the passage of time. So there is a paradigm shift towards reduce or no immune suppression currently. In the past 10 years, there has been a shift towards using treatment with reduced or no immune suppression, such as erythropoietin receptor agonist, TPORA. This shift has been accelerated actually by the COVID-19 pandemic, making it more important to develop non-immune suppression strategies for acute autoimmune thrombocytopenic purpura. TPORA efficacy, these are the new class of drugs that have shown to be effective in increasing the platelet count and reducing bleeding tendency in ITP patients. And they are generally well tolerated with a very good safety profile and lower risk of side effect as compared to the older therapy. So personalized treatment is usually recommended for ITP patient. Why? Because the ITP manifestation is different. Patient presentation is different. Some patient, usually majority patient are asymptomatic. Some patient present with mild mucocutaneous bleed. And only 5% patient present with major life-threatening bleed. Similarly, the disease progress can also differ. Some individuals experience spontaneous remission within 6 months, while others developing chronic ITP requiring continuous monitoring and second-line treatment. So certain patient characteristics are also important apart from the platelet count before deciding a second-line therapy, which include the patient age, like splenectomy is contraindicated after the age of 55. Then there is previous bleeding history and presence of comorbidities, as I mentioned, CKD, malignancy, and ischemic heart disease, and the presence of like certain medications. Those patients who are asymptomatic with a platelet count of more than 30,000, they usually don't require any treatment. But symptomatic thrombocytopenia patient with a platelet count of less than 30,000 requires treatment. This is one of the indication. Then the platelet count less than 10,000, irrespective of the symptomatology, these patients need to be treated. Then the rapidly falling platelet count are likely to become symptomatic again is an indication. The history of major bleeding, and similarly if a patient is planned for any surgery or procedure, they need to be treated and their platelet count need to be optimized before this procedure. So steroid again are the first line treatment. Usually we treat the patient with prednisolone or dexamethasone. Some investigator, even in our setup, reported higher response rate or remission rate with pulse dexamethasone and methylprednisolone as compared to oral prednisolone. IVIG first-line therapy, but it can be used before any planned procedure or in emergency condition when the patient presents with life-threatening bleed, and it is usually combined with prednisolone or dexamethasone or intravenous methylprednisolone, or when there is a need for more rapid response in acute emergency. So what about second-line treatment? There is no consensus on which second-line treatment for ITP should be attempted first. There is no reliable predictor of response to second-line treatment even. But generally, patients need to be switched to second-line treatment when the first-line treatment is not obtained a hemostatic response, as the risk of bleeding and mortality increases with a platelet count of less than 20,000. So the treatment aim to achieve a platelet count of more than 20,000 and avoidance the risk of severe bleed. So what is treatment failure? It is basically inadequate hemostatic response, which means platelet count of less than 20,000 with more than 5 milligram per day of prednisone, 3 to 4 cycle of high dose dexamethasone, and 1 or more courses of IVIG represent failure of first line treatment, and these patients need to be considered for second line treatment. Second line treatment options are 3 currently: splenectomy, thrombopoietin receptor agonist, and rituximab. And the choice depends upon the patient preference first. Like some patients, if they avoid surgery, need to be considered. If patient to avoid daily medication, it need to be considered. Then the second factor is age, as I mentioned. Splenectomy is contraindicated after the age of 55. Then of course the lifestyle, the presence of comorbidities, and the availability of drug, as Dr. Irfan rightly mentioned. Thrombopoietin receptor agonist and rituximab is not easily available, though it's available in tertiary care hospital. So this slide shows the comparison of 3 treatment modality in second line treatment: splenectomy, TPORA, and rituximab. If we see the early response rate, it's quite good, 85% with splenectomy. Splenectomy karo, kissa khatam karo. With TPORA, response rate is 70 to 80%, almost similar to splenectomy. With rituximab, it's 50 to 60%. Then if we see sustained response rate, it's 60 to 70% with splenectomy, 70 to 80% with TPORA, and 20% with rituximab when we stop treatment. Remission rate with splenectomy is still high. It drops to 30 to 40% with TPORA, and that is the biggest problem. And with rituximab, it's 20%. Financial burden is high with TPORA and rituximab. And the positive clinical aspect, like in splenectomy, long-term remission, no need of chronic treatment and avoidance of medication side effects. With TPORA, it is generally well tolerated with high response rate, multiple therapeutic option, like we can switch easily from one generation of TPORA to second, and avoidance of surgery. This is the minimal platelet count which is required for different procedure, like you can read it from the slide. I think we are short of time. 1 minute. Second line treatment, as I mentioned, it's TPORA, rituximab, and splenectomy. Splenectomy is associated with the durable remission of a long-term response rate of 70%, and it can be considered in patients whose age is less than 65 with disease duration of more than 12 months, and for whom this option impact least on their lifestyle. Rituximab is anti-CD20 antibodies, which leads to depletion of B lymphocytes, and it need to be administered, should be considered in patients who have expressed a strong preference to avoid surgery, and it is generally considered in young female patient of less than 40 years with a disease duration of less than 1 to 2 years, and those who want to avoid thrombosis, and those who want to avoid splenectomy. TPORA, eltrombopag and ramiplastin have been validated in various randomized controlled trial. It has got a good remission rate, and it is generally recommended in patients who want to avoid infection with having some immune deficiency syndrome and who want to avoid splenectomy. Approximately 10 to 30% of patients can discontinue TPORA and maintain a treatment-free response. And the discontinuation criteria, if the patient platelet count remains more than 50,000 for 6 to 12 months, in this case we can consider the discontinuation of the drug. These TPO are generally approved for treatment of chronic ITP following splenectomy or in patient in whom splenectomy is contraindicated. And this was a study which was conducted at Aga Khan, in which 29% patients were involved, and good response rate was achieved in 86.2% of the patients. So the take-home message is ITP is a diagnosis of exclusion. Rule out all other causes of thrombocytopenia before making its diagnosis. In last 10 years, there has been a shift towards zero or no immune suppression. Personalized treatment approach is crucial for the diagnosis of ITP. Second line treatment is generally considered for patient with inadequate hemostatic response, and TPORA, rituximab and splenectomy are the three main treatment options in second line management currently. Thank you.
Thank you. Thank you so much, madam.